Hey, welcome back. And for those that randomly just found me, thanks. I'm happy to have you guys with me today. We're going to talk just about infections again, a little bit more. I got a question. I'll just put it up. Hey, Doc, what's your preferred antibiotic choice for patients that are allergic to amoxicillin or penicillin for larger surgeries? Yeah, I mean, I think this person obviously just wants a quick answer. I mean, yeah, penallergic. Avalox, moxifloxacin, good choice generally for what we do, oral sinus, that kind of stuff. But larger surgeries, is this for pre-op antibiotics, post-op? Is this for an infection? The question doesn't have all the information, right? So we're going to kind of just do a little bit deeper dive into, again, antibiotic selection. I know this is super dry, but I'm going to try not to make it super dry. So let's see what we got. So this is, from last time, I do go to Up to Date quite a bit. It's a great resource for medical information, antibiotics, drugs, things like that. So this one is basically saying, why clindamycin sucks, and it's continuously updated. So again, from Up to Date, they're saying clindamycin is not recommended for initial empiric therapy due to resistance among streptococcus, like strep malariae. If any dental student is listening, or recent dental grad, or dental hygienist, and so forth, you've definitely heard of strep malariae, right? Commensal organisms in the mouth also cause infections, right? 20 to 30% resistance of that group of strep with Clinda. It's pretty big. And also anaerobic bacteria, like 38% resistance with Clinda. So yeah, that's again reasons why I don't use it for bigger infections. Anything that I think that may spread. I try not to use clindamycin. But for a general prophylactic, zit, sure, yeah. And so what can you use? So again, this is from Up to Date. So some other options, if you can't use Augmentin, which is the best thing usually, or penicillin, which is also Augmentin, but penicillin plus something else. I generally, like I said before, I go to Avalox, which is moxifloxacin, 400 milligrams, POQ day, and generally like 7 to 10 days, or resolution of clinical symptoms, basically, or inflammation. You can also use a second or third generation cephalosporins. So they're recommending here cefuroxime, 500 milligrams BID, or cefdinir, 300 milligrams BID, plus metronidazole. Again, when you're adding multiple antibiotics on different, like metronidazole is usually dosed 3 times a day. And so like you're taking multiple pills at different times. For compliance issues, for some people, that's hard. The other option, like I said, is Avalox, which is 1 pill once a day. And compliance issues, the best, right? And it works well. So quick answer, long answer, there you go. And generally, Up to Date is saying, you want to continue these antibiotics for as long as the clinical inflammation is present. Generally, 7 to 14 days is normal. You should see a turnaround, if they're working, and if you need drainage or something of the abscess with that, you should see a turnaround probably 3 to 4 days. So that's good. And again, so why Clinda is not so great sometimes, or a lot of times, it doesn't cover those strep groups, like we said before, anaerobic bacteria and malaria as well. This guy, you can see the significant facial swelling. He got worse on clindamycin as an outpatient, and ended up, having surgical drainage with multiple empiric antibiotics IV, then went to oral and got better after drainage. So, yeah, they tried to manage him as an outpatient with Clinda, and it actually did worse for him. This lady, vestibular abscess, basically an abscess in the mouth. It's localized around the teeth, and then after a while, not getting better as an outpatient, started getting facial swelling from it, right? So now it's spreading side of the mandible, and then at some point, if it's not stopped, it'll go to the neck. It can go to the other side of the neck, and then you have a bigger problem, right? Another patient here, this just started from one tooth, upper left canine, developed a canine space infection that spread to the buccal space, and then just kept going until we got it under control. But yeah, you can see just one tooth can cause significant swelling and pain. This is another case. Try to be managed as an outpatient. This went into multiple spaces, and I have a pretty deep dive into this case, somewhere on my Instagram and YouTube and stuff. But buccal space, temporal space, spassoteric space, everything, and which is interesting on this case, like on day 21, after the huge abscess was treated, all he was left was this little seroma, not even an abscess, just lateral to his eye, which I just drained really quickly in the clinic. And there wasn't pus in there. It's just so much swelling had occurred over a short amount of time that all this, fluid needed somewhere to go, and their normal pathways were blocked. So he just developed this little seroma. So somewhere on there on my feed, you'll see me draining that. It's just yellow fluid that comes out of there. It's not pus. And you can see, again, it's multiple spaces, and this is how fast and aggressive these infections can be. So if you're on the wrong antibiotic and it's getting worse, you're actually creating a bigger problem in a lot of cases because now you have this resistant strain. And I'm just going to close with this case here. Sorry, this case here. It's interesting. So a person like this can have multiple teeth with localized inflammation, swelling, calculus buildup, even, right? But for some people, this just kind of stays in the mouth. It doesn't spread to the neck. I can't predict when or if that's going to happen, and nobody really can. But you can see people can live with a lot of decay and localized inflammation without showing it outside the mouth. Again, for most people, you definitely want to get treated. Don't want that to happen. Thank you.